Hello, everyone. Welcome back to our Impact broadcast. So this is different from our podcast. We are together today. We're really it's a really a pleasure, honor, not because we have huge expert, but I also need to say friends. I want to first of all introduce Elsa Gimelli because she's the editor in chief. And thanks to Alessia, we can do this amazing project. So, Alessia, welcome and thank you so much always.
Thank you, Eduardo, and welcome, Maurizio and Carl. So, it's a great honor for me to have you on board in this Impact broadcast in this new episode. As you probably know, this project was born from a very simple idea. We would like to bring together cardiovascular imaging and intervention community with a conversation on real clinical challenges in some way. And for the first time, we opened the floor to our audience in advance. So many of you submitted questions through our dedicated email. So thank you very much for your engagement, and your input helps to shape the dialogue and makes this space in some way very interactive. So let's dive in. We are here to explore where we stand and where we are in the treatment of primary mitral regurgitation. So Eduardo, please, let's start.
Thank you, Alessia. So again, thank you, Maurizio, also from me and from also thank you, Carl. So the thing is, there is a state-of-art review just published actually in our journal about primary MR, because primary MR, we know that some trial will come up and still we have a lot of evidence across surgery, across transcatheter, and I think having Maurizio, which is an hybrid surgeon, and having Carl, which is an interventional cardiologist, I think it's the best way to a little bit make a little bit of a clear idea on this topic, I would say. So, Maurizio, I want to start with you. So you are an hybrid surgeon, so you really have a clear view on both fields. So what do you think about, which is your perspective on this panorama for the treatment of primary MR?
So thanks for the question, Eduardo, and thanks for the invitation, Eduardo and Alessia. And I think from my perspective, primary MR, when we talk about primary MR, let's say in Europe or in the Western country, we refer mainly to degenerative MR. So we'll focus on degenerative MR. And degenerative MR is somehow a spectrum of different complex anatomy. So we go from simple lesion where we have, for example, single scallop, flail, or prolapse, moving toward the most complex pathology, which is Barlow valve, where we have multiple scallops. So it's not only one single entity. It's a multiplicity of anatomy, multiplicity of pathology, and this, of course, needs a multiplicity of approaches. By the way, this kind of disease affect young patient as well as elderly patient. The prevalence increase with age. So we have a multiplicity of anatomy and pathology. We have valve that can be also calcific. We have valve that can be really difficult to address and not amenable to be repaired. And then we have different patients. We have easy patients which are young and do not have any big copathology. And then we have old patients with a lot of copathology and disease. So we really need a spectrum of treatment to address this different spectrum of pathology. And of course, the easiest is the pathology. The easiest is also to achieve good result, which is our target, is to achieve good result and ideally to neutralize the disease. I think in DMR, our aim should be to neutralize the disease, so to basically cure the problem without leaving any consequence on the patient. So ideally no scar on the patient, no arrhythmia, no need for medication, no risk of infection, no gradient through the valve, no prosthesis, no residual MR, and durable result. And this is achievable most of the time with minimally invasive mitral valve surgery. I think this is still the best option for the vast majority of the patient with DMR. Obviously, this implies also a certain degree of experience by the operator. Not all the operator, not all the team are performing the same quality of mitral valve repair. And this has to be taken into account. So the expertise of the center performing the surgery is extremely important to achieve this kind of neutralization of the disease. Also, the timing of the treatment is important. We need to address the disease before there are irreversible consequences on the heart, like dilation of the heart chamber, long-standing atrial fibrillation, fibrosis. So we need to have proper indication and proper treatment. And then obviously we have patients where this kind of treatment, which is at the moment the best treatment for DMR, is not achievable with acceptable risk. So elderly patient or patient with copathology or patient where for any reason surgery cannot be performed with low or acceptable risk. And in those patients, transcatheter treatment has a major role. At the moment, the major player in this field is TEER, so mitral clip or Pascal. We have now data showing also good result in terms of durability. We don't have extremely long-term durability, but we have mid-term excellent durability. And in those patients is fundamental as well the expertise of the team, not only of the operator, but also of the imaging team, which is guiding the procedure. So again, performance matter in both surgery and transcatheter and DMR.
Sorry, may I ask you just a very simple question? Is there any difference between women and men in terms of approach, in terms of outcome? Which is the state of the art in terms of real data?
There are no, let's say, big data in terms of differentiation of outcome among men and women. There may be some difference in the prevalence of the disease and eventually in the penetration of the treatment in some geography especially, but there are no, let's say, big data. At the moment, there is no big differentiation according to the sex of the patient with regard to the approach. We may say that women probably somehow could have higher risk of stenosis if they undergo mitral clip or Pascal, for example, because they are supposed to have, let's say, smaller valve, but they have also probably smaller BFAs. But there are no data with this regard, at least to my knowledge. So no, there is no differentiated approach.
Okay.
Thank you so much.
Yeah, Carl, sorry, just to link the two things. So I wanted to see your perspective on this panorama of treatment of primary MR because, but also a bit, what do you think about the next trials that are coming up, also regarding to the guidelines? So what do you think about that? Because I think it's interesting to see that actually the repair, the surgical repair now of surgery, which is been the gold standard for like ever. Now it's really been in discussion with transcatheter, of course, in patient that fits. So what do you think about that?
I mean, I think I totally agree, first of all, with Maurizio, who very much said that primary MR or DMR, it is a very mechanical problem. So in order to really treat those patients, you have to fix the mechanical problem. And this is what surgery was and is still doing better than what we can achieve with percutaneous results. And when we now look at the guideline recommendations, they favor in those patients surgical approaches over percutaneous approaches, which is based on the Everest 2 data, where we quite frankly have to say that those were very early. I mean, we were as interventional cardiologists at a very early experience stage compared to surgeons with way more experience and knowledge about the mitral valve when we did those procedures. And since then, as you already said, we have 2 upcoming trials which are looking specifically into those patients with primary MR compared to surgery. We do not really have new data in this field, but what we have is like data from the Matterhorn trial, which compared patients with secondary MR, and there we could see that there was a non-inferiority with all regards to the procedural result, but also to outcomes. And what we saw is, and this is somehow expected, that we will see more adverse events in those patients when we treat them surgically. But it's not like that we can propagate those results to primary MR. This is still a very different population. As Maurizio also very correctly said, it's very important that you get those patients in the right stages where you are not having concomitant left-sided heart disease, because for those patients there is no medical treatment. I mean, nobody would start doing for aortic stenosis with patients medical treatment. It's a very mechanical problem. If we fix it, we usually will have very good results. And so I think in the light of the present available evidence, there will be not a big change in the upcoming guidelines for the recommendations for primary MR. I mean, we can percutaneously nowadays achieve way better results than we could in the Everest 2 trial. So this is definitely something that will be considered, and maybe there will be an upgrade for the quality of tier. But still, I think if patients have acceptable surgical risk and anatomy that is treatable with surgery, surgery will remain the gold standard up until we have new evidence that compares it. But what I think is a beautiful thing about those interventional therapies coming up is that the surgery has for a long time in the field of valvular heart disease been like this solo player, and now they're getting a second part to play with, and they stepped up their game in line with this. I mean, obviously they have been progressing, but when you look at our progression in interventional approaches, but also our understanding in AV valve disease, it has significantly stepped up in the last few years. But this is because we have a good interaction of surgery and percutaneous treatment, which is really propelling the field for both surgeons and interventional cardiologists. So I think it's a very good road we're on.
Okay, but that's interesting because actually you mentioned something. I remember a question from one of the audience that have sent to us that was actually going in this direction, like the new devices, because they were asking about neocord, and maybe the combination and things like that. So this is also perspective, right, Maurizio? What do you think? I mean, also the new devices that are coming up, because except from tier, what can we say about that?
Yeah, regarding repair approach, I think what is really appealing and is coming quite slow because it's not that easy to perform and in a proper way, but it's coming, is transeptal or percutaneous chordal implantation. And the reason of that is that there is actually the possibility, the promise to address the problem, just leaving let's say, a really minimal footprint on the valve. So the idea is that if you can address a flail or a prolapse with neocore, which are delivered through transeptal approach, and then in case of failure, you do not preclude the reparability of the valve, or you do not preclude the feasibility of other repair approaches, whatever surgical or transcatheter. And this is appealing because potentially could expand the indication also to low risk younger patient, because you do not actually preclude then the possibility to have a surgical repair. So if you treat with transcatheter chordal implantation a patient which is young with early indication, the annulus is not dilated yet, potentially, I mean, you can solve the problem, and if the problem comes again or if the treatment fails, you can still offer him the best treatment, which is so far surgical treatment for this kind of pathology. So obviously you can address high-risk patients as we are addressing now, but you can potentially expand also the indication to younger and early treatment. Obviously, this has to be proven. It's not given for granted that if you
Yeah.
implant cord, then you can still repair the valve with the
Yeah.
same chance of successful repair, but it's extremely appealing. So I think this kind of approach is really, really the most promising for the future, beside the tier, of course, beside improvement of tier technology. Then the second is obviously the combination of therapy, as you said. Obviously, annuloplasty would be extremely important. There have been several devices already working on annuloplasty through transcatheter approach over the year, but at the moment is not established yet. But obviously, we are looking forward to have it as a standalone therapy and as a combined to leaflet repair. And last but not least, it's not a device, but improvement of imaging guidance. Obviously, eyes and
Yeah.
for the eyes becoming more and more available and more advanced, fusion imaging, so better planning and better guidance will also definitely improve the result of transcatheter treatment and probably also of surgical treatment. So I think these are the field that will improve the field overall in the next few years.
So this is a very interesting perspective. May I ask, Carl, because I know that you are also an expert on AI. According to what Maurizio said, do you think that also, for example, the models of physical and digital twins can be of help in the planning of this kind of new treatment or in the evaluation of very high-risk patients?
Yes, definitely. I think those are very, very important aspects that are upcoming, as you said, especially for those cases which are really challenging and where the heart team is really prone to shine when we really put down synergies and have hybrid surgeons also who have the expertise in both areas, then we can really excel and get the best results for our patients. But with those new devices in mind, I think what we have to keep in mind is why the adoption of edge-to-edge repair devices has been so successful is their ease and safety of use. And this is something that has been, for example, for annuloplasty device, if you implanted it in percutaneous, the procedure itself was so tedious and so long that a lot of the interventional cardiologists, they get frustrated when they were doing it. And so this is definitely something that will be very important when we have those new devices, that we also really work on the way how we can use them and make them approachable for interventionalists. That the procedure itself is not only safe, which is obviously the most important concern, and effective, but also that it is time effective and that we can do it in reasonable time frames, because this is what has really propelled the spread of edge-to-edge repair.
Thank you so much. So I think that probably it's time to close. So
Yeah,
I'm very
unfortunately,
happy
yeah.
to have you on board. If you would like to add something else, just to summarize, to sum up, or do you think that it's very important to cover other aspects that we didn't ask you by several questions? Or please let us know. The floor is yours. Just to sum up.
Yeah.
Very one
Expert,
sentence. What do you
exactly.
think
Expert
that
sentence.
will be the future of this type of treatment?
Maybe I can start. First of all, thank you. It was really fast. It looked like we talk only 2 minutes, but it's already almost more than 20 minutes.
Yeah.
To summarize, I think, first of all, we are talking about really sophisticated new devices, but we should really, before of going in that direction, increase the awareness overall in the general cardiology community to increase the diagnosis, because probably this is still an underdiagnosed disease, and it is a lethal disease if not treated. I mean, it has really detrimental effect on the heart. So we should really try to do this kind of broadcast or webcast to try to increase the let's say the to spread the word that there are many patients still not diagnosed. And this is the first thing. And then obviously, the more we will have tools, the more it's going to be difficult to use the correct tool for the correct patient. So we need data. And this is what we are trying to build up, knowledge in this field to help us and to help the heart team to guide the decision and to use the right tool for the right patient.
Yeah,
Thank
absolutely.
you so much. This is
Carl, what
very
do you think?
important.
Carl, what do you think?
Maybe from my side, when I think back when I finished my study, which was in Graz, it was something very special where we had one mitral fit case, and this was very early. And when I look back at the time, how many devices are nowadays available, I think we live in a really fascinating time of interventional cardiology, where we have new devices every year, and our understanding of the disease, and this is something also in line with what Maurizio said, is that we acknowledge the disease, we're able to detect it earlier, we understand the dynamic nature of mitral regurgitation. So definitely, I believe, and this is also something which refers to what Alessio said, we will have to identify those patients early and identify risk factors, maybe even in those that are not already getting symptoms, but really treat those patients as early as possible to avoid that any kind of cardiac damage already is induced, which usually then leads to symptoms. But really get those patients early and treat them well. But I think we're really on a good way for this. So, and also from my side, thank you very much for having me in this fantastic.
Thank you so much. Thank you so much, Maurizio. Thank you so much, Carl. And of course, thank you so much, Alessia, because without you, this would not be possible, honestly. So, just to close the broadcast, remember there is the article to read, the state of art, actually in our journal. And remember to put the alert so you will see when the episode will be online, and also not only for the broadcast, but also for the podcast and everything. So, thank you so much, and see you next time.